This is the Coordinating Care for Diabetes Patients voice over PowerPoint presentation. As you go through these slides, you will see a little, it's kind of like a megaphone, and you will click on that. It will have information regarding each of the slides that you will see. About diabetes, we have to talk about insulin, we have to talk about the cell, and one of the analogies that we use, and I think this is one of the best, is of a key and of a lock on a door. So you see this picture here, our insulin is the key. So in order to get inside the cell, we need to have insulin. So if sugar needs to move across that membrane, the glucose needs to go into the cell, we have to have something that lets it go in, and that's our insulin, which is a hormone. So remember when we talked in MedSurg about potassium going in, and they're all going into the party. So in order to go in, they have to have insulin. When we don't have enough insulin, when the pancreas is either damaged or sick, like with pancreatitis, then we're not producing the insulin we need. Therefore, sugar, glucose, is not going into the cell. It's staying outside of the cell, and it is raising our blood glucose level. This is what happens when we have diabetes. We don't have enough insulin. We don't have enough keys to allow glucose into the cell. Diabetes is one of those diseases that has a wide variety of manifestations. It also has really, we have to understand that it's kind of on a spectrum. So people can have very mild diabetes, people can have very severe diabetes, and sometimes you'll hear them called as brittle diabetics. Overall, we need to understand that the damage that is occurring, even if they don't realize it's occurring, is very serious. We have wide-ranging systemic effects. It damages our vessels, contributes to the development of that cardiovascular disease, hypertension, kidney disease, neuropathy, and retinopathy. It is more common in our African American populations, Native American and Hispanic populations, and is a little more common in males than females. There's certainly a genetic component to this, but what you need to understand is that even if your patients aren't necessarily feeling symptoms and they don't feel bad with this diagnosis, that it still needs treatment and monitoring and measurement to make sure that we don't have this additional damage. We know long term it can cause blindness, it can cause limb loss, it can cause severe cardiovascular issues. And by the time that those things are occurring, the damages are already permanent. So we need to encourage our patients to understand how they can affect and manage this disease right now. It's very important that we are doing regular screenings. This is done usually with a blood draw, so we can get an A1C, or we can do a finger poke if this is someone we already know is established with diabetes. But we want to look if someone has a BMI above 25, if somebody has a relative that has diabetes, if you're older than 45, if you have a sedentary lifestyle, a history of vascular disease, and polycystic ovarian syndrome. We want to look at certain ethnic groups and hypertension. We want to look at that person who has a history of that A1C being over 5.7, some issues with glucose, and then our elevated triglyceride levels. So this is not going to be done with just kind of a poke and done. We want to get an A1C. We want to make sure that we're getting a good picture of what's been going on for the last, I think it's about 3 months. And we get an A1C because our little red blood cells, if we have way too much sugar in our blood, that sugar sticks to the outside of the blood cells. So then what they do is they measure how much of that is actually on there, and it lets us know how well controlled our blood sugar is. If it's higher, we have diabetes. That means we have got way too much glucose in our blood. If it's below our 5.7, we know it's better controlled. Of course, there's going to be some natural fluctuations if you eat more glucose. If you, are very active, we're going to have, certain level variations. But the A1C, specifically looking over those 3 months to see how well controlled this is. And if it's elevated, we know it's not controlled very well at all. So this slide is talking about our hypoglycemia, which is our low blood sugar, and our hyperglycemia, which is our elevated blood glucose. So what we have to look at are our signs and symptoms. And the best thing you can do is obviously take a little finger poke and see kind of where they're at the moment. But there's going to be some physical manifestations too that you should see. You may have heard the idea of cold and clammy, give some candy, hot and dry, shoot the thigh. Those are our little sayings where we know that if somebody is hypoglycemic, they're going to feel cold and clammy. If they're hyperglycemic, they're hot and dry, shoot the thigh, meaning they need some insulin. So definitely take a look at these symptoms. I want you to understand, though, it really varies. It varies on the person. Some people can be a blood glucose of 500 and be in DKA. Some folks that always run really high could be 1,000 and they're doing fine and walking about. And, it just really varies on the individual. Again, understand that this is on a spectrum. We are looking at how patients are very symptomatic, and this is really true across the board with all sorts of diseases. Are they symptomatic? Not that you're not going to treat if, they're 750 and they're not symptomatic. We definitely want it lower because we know that that blood glucose is causing so much damage to our vessels, being that high. But understand that, we are going to see these symptoms when people are just, not feeling really great. So make sure for an exam you can identify, hey, if they say this person is urinating a lot, they've got hot, dry skin, they're feeling really tired, and they have some blurred vision, that you're like, I think I'm going to be considering hyperglycemia as a possibility of why they're not feeling really good. So take a look at these and definitely know those for an exam. So typically we understand diabetes having 2 types. There is a diabetes type 1, which tends to be a autoimmune disease where the body has attacked the pancreas, destroying beta cells, leaving the person either with a very reduced capacity to produce insulin or no ability to produce insulin. These folks are insulin dependent. They cannot be without insulin. Otherwise, they're going to die. Risk factors, family history, some autoimmune diseases, viral infection. Typically, we see these in people that are under the age of 30, but you can have a type 1, diagnosed older than that. When we discuss type 1 and type 2, I want you to understand that they kind of bleed a little bit over into each other. Sometimes there's a very, very clear difference between the two of them. Sometimes, you'll see that type 2 and their pancreas just stops. So, technically, if they have severe autoimmune disease, they're technically now kind of a type 1. So this is in general how we describe these things. Our type 2 is our older patient, but we'll go into that in a smidge. Understand that type 1 cannot live without insulin. This is not a patient that is on metformin. This is not a patient who is on glyphosate. This is a person who has insulin injections and probably a pump. This is very serious if it's not dealt with and not maintained. So it does take quite a bit of an education to make sure that they understand, their diet, how to dose insulin, all of that stuff. So let's go on to the next slide. Okay, so our diabetes type 1, we have our signs and symptoms. A lot of what we see are these 3 Ps, polyuria, polydipsia, and polyphagia. So the body is not taking in what it should because we have no insulin pulling glucose into the cells. This causes us to urinate a lot, to be super, super thirsty even though we're drinking a lot, and very hungry because we're not pulling into our cells what we need to pull in. So you'll see weight loss, fatigue, lots of infections, rapid onset, insulin dependence. This tends to be something that can be more familial, found in the family. And we tend to see this in children. They can be literally 6 months old, they could be 12. This is pretty much a sudden onset, and it is something that we need to definitely deal with and educate our families on. So insulin is released when blood glucose spikes after meals. What we're going to do is check our blood glucose before the meals and then administer insulin. Basically, that is going to respond the same way the pancreas responds. We're going to see those elevated levels. Now, like with our type 1, if we don't have fuel for our body, it's going to start breaking down our proteins and our fats to make sure that we have fuel. That's why we see that weight loss. So we're going to check our blood glucose. It could be after every single meal, and usually in the hospital, that's kind of how they do it. However, I have seen it where it's once daily. Maybe people don't like the pokes as much. Obviously follow your orders, and that's how you're going to do it. Usually they're standard orders, and we'll adjust as needed. So when we look at our type 1 diagnosis and our treatment, understanding there's just going to be a ton of education that's really needed for this patient. Not just how to take your medications, but dietary issues. If this person, if your patient's a child, then we really have to get the family involved and the parent and the guardian. We have to maybe get social work involved to see if they can afford their medications. This is a big, profound change for a lot of folks, especially if they haven't dealt with it before. So, we're going to look at an A1C, we're going to look at a fasting glucose. This is a person who is insulin dependent. They will be on insulin. How do we, look at their diet and address their diet? Does the patient understand how to take care of their medications? If they're a child, do their parents, do their guardians know how to take care of their medications? What do they do if there's problems? How do we prevent complications? How do we detect when there's complications? What happens if, they're more likely, to get infections? Okay, so then what are our signs and symptoms of infections? It's really important to understand that this is not going to be a 5-minute education process. This is going to be quite extensive. So hopefully with the type 1, they have an endocrinologist, or they have, again, this can be diagnosed with, family medicine, but you definitely want an extensive level of education to make sure they know what they're doing, and they have the resources that they can either follow up with you, or they can follow up with someone to make sure that this is being handled correctly. Some very serious complications when it comes to type 1 diabetes. Our type 1 has these effects. You've probably heard of diabetic ketoacidosis. That is when we have a really high level of ketones in the blood, really high level of blood glucose, and our patient is now in a metabolic acidosis. So our body functions aren't working very well, nothing's getting processed, our toxins are building up, and this does require medical intervention. These folks are in the ICU, they are being monitored at least hourly, and they are usually on an insulin pump so we can hopefully correct what's going on. Hypoglycemia, very, very serious complication. We don't have the amount of sugar or glucose we need. Therefore, our cells are not getting the energy that they need, it can cause a lot of, nausea. It can cause shakiness and general feelings of unwellness. If we don't have that fuel, then our brain does not have that fuel and it is not happy. Dawn effect is a form of hyperglycemia. Dawn effect is when the cortisol and the growth hormone at night is released, and it signals the liver to boost production of glucose, which should help with the energy for waking up. So we've got these hormones that are going on, causing our blood glucose to increase. Our Samoji effect is similar. It is also a hyperglycemia. It is a rebound effect from low blood sugar, like basically after your evening meal and your dosing of insulin, you kind of fall throughout the night, so you have low blood sugar, and then now your body, because it doesn't have fuel, is starting to catch up with the insulin, and now we have hyperglycemia. I'd like to add on here a little bit about the Kusamal's respirations. I don't think I touched on them with DKA. One of the symptoms you could see in the very beginning of Kusamal's respirations is this quick, shallow breathing in the very beginning, and then as it progresses, you get a very deep, quick, labored breathing. And we have to understand this is a acidosis, meaning that our body is trying to fix something. We're too acidic. The quickest way our body can do this is start to kick out the carbon dioxide, which is acidic, to try and balance out our body. So that's called the Kusamal's respirations, and just understand that this could be something that we're seeing with diabetic ketoacidosis. So hypoglycemia is life-threatening. So is hyperglycemia, but hypoglycemia tends to be a little quicker and a little more life-threatening, quicker than hyperglycemia. Obviously, both can kill you. It can be a life-threatening emergency. It does mean we have way low amounts of glucose. So we have the insulin, we just don't have any fuel to push into the cells. So we need that kind of constant supply of glucose, and if we don't get it, then our body is extremely unhappy, especially our brain. Our brain loves glucose. It is the only fuel that it uses. If it doesn't have it, it's going to start breaking down proteins. It's going to start breaking down fats. Everything is going to get broken down so the brain can survive. The most important thing for the body is that that brain is surviving. Now, one of the things that you'll see is a lot of confusion with these patients. They are what I call, even if they're conscious, they have what I call diabetic brain, meaning that they don't follow instructions very well. You are going to have to manage this for them, and I've seen it firsthand where you have someone who has a blood glucose of 50 and you're like, well, here, drink some juice, and they don't understand what you're telling them, because even though they're awake, they're not processing the information you're giving them. So this is where you probably can't hand them a sandwich and walk away. This is something where you're going to have to give them dextrose if they can't follow commands. This will be something where if we don't fix it, they're going to start having some trouble. So don't just assume if you hand them a glass of juice that they're going to drink it, because I've seen many times where they just don't follow through because the little synapses aren't firing. They don't have enough fuel. Their brain is not responding quite the same way, even if they're fully conscious. So treat hypoglycemia always as an emergency, and stay with them and make sure that they're eating their food, that they're drinking their juice, that they're, sucking on that candy or something, so that we can get them back to normal. So it's going to be very important that we do a good assessment on these patients. We want their vital signs. We want to stop DKA before it happens, and you're going to see those vital signs, things like tachycardia, before we actually get into the more severe signs. We want a serum glucose. In the hospital, it's usually monitored before meals at least 3 times a day. We want the potassium levels, because we know that our insulin and our dextrose or glucose or whatever the sugar is being pulled into the cell is also pulling in potassium. So is the level high? Is the level low? Do we have polyuria? And we're urinating out all of our potassium. And we know that if we have potassium levels that are too low or too high, we're going to have some serious cardiac issues. So let's check those potassium levels. Let's check our input and output. Again, polyuria, we're going to be very, very dehydrated. We want to make sure that everything is in balance. Our carbohydrate intake is very important. Most people associate diabetes with not being able to have any carbohydrates. That is not true. We need a balance. This is something that a good, get your hospital nutritionist, someone that can come in and definitely help explain to them what you need to have, the protein, the carb, and the, your vegetables, and which amount is correct for them. So make sure you're doing a complete and very thorough assessment. So when we look at our nursing interventions, this is a little more difficult to discuss because it's going to be very hospital dependent. They're going to have a plan of how they want you to treat the, the DKA or, your hyperglycemia. So follow your hospital protocol, but it always does involve glucose monitoring. Usually it's every hour. Administer insulin. They will have basically a sliding scale, or like I said, if it's DKA and you're running like a drip of insulin, you're going to have a certain scale and a certain protocol that they want you to follow. Usually we also have some isotonic fluids and some dextrose, possibly. Like I said, it depends on the order. But remember, these folks are very, very dehydrated. They have that severe polyuria. So we need to make sure that we are, hydrating them, getting the insulin, and not just the insulin. We want to give them some dextrose. We want some fuel for them to push into the cell. So what we want to do is teach our patients, again, the signs and symptoms of hypo or hyperglycemia, how to take their insulin, what, why, how, what are they doing? What's the point of all of this? Meaning that they need to have an education of why this is happening to them and not just, hey, it's something I can ignore and pretend is going to go away. We have to have fuel for ourselves. If we don't, not only are we causing severe vascular damage, we can be causing, DKA, we can be causing all sorts of injury to ourselves, and it's just not good. So they have to monitor their blood glucose and they have to maintain a healthy diet. This is something that, again, we're not experts on nutrition, not as a nurse. So it's very important that we make sure to, get somebody who can educate your patient on a diet, a diabetic diet, and how we need to balance our carbs and our proteins together. So we have lots of different options when it comes to giving an insulin dose. We have just the regular sub-Q route where we're going to kind of inject it into that subcutaneous fat. We have pens, pretty much dummy proof it. You set it to the dose you want, you put it on the skin, and you push the button, and there you go. We also have pumps. And the pumps are, again, probably for folks that are a little more severe, where we have a need for really constant monitoring. You'll see those around and about. We have on the slide the location, sub-Q fat under the belly button. We have the thighs, back of the arms. I'm a huge fan of the back of the arms, especially in the hospital, because the patient typically cannot inject themselves in the back of the arm. So we have very tender skin at the abdomen and at the thigh. So when you do the back of the arm, it really gives that skin a break. So you don't get that, it's not as painful, and it, lets the skin in the other areas heal. And so I would always recommend doing the back of the arm if they're okay with that. So after we administer insulin, we do need to watch for our hypoglycemic issues. These dosages will need to be adjusted. especially around procedures and anything that is requiring fasting or a person cannot eat. We have to understand that our diabetic medications may have to be adjusted frequently in and out of the hospital. Prior to discharge, we want to make sure that we watch them do the medication, because a lot of times you'll get some head nodding and, oh yeah, I get it. And then they get home and they have no idea what they're doing. So we need to make sure that they understand what they're doing. This is a lot of education. So learning how to inject yourself, learning how to take your medication properly. Newly diagnosed diabetics have a lot of catching up to do, because it is a very lengthy medication process. So make sure that they have a good understanding and can repeat back to you what they need to do and can show you what they need to do. Type 2 diabetes is considered an insulin resistance. This is when our cell membrane kind of resists that transport of glucose into the cell. So the best way of understanding type 2 versus type 1 is, remember that key analogy that we had in the very beginning. So in type 1, we don't have a key. There's no key to get into the door. So then our sugar and our glucose just keeps building up in the blood. With our type 2, this is different. We have a key, but the key is bent. So it doesn't work very well, and we're trying to jiggle it and we're trying to get into the cell, get in that door, but it doesn't work because what we have is not sufficient. Now it can be because of age, because maybe the pancreas is not producing a good quality insulin anymore, or not enough insulin anymore. It can be because of obesity, so we have so many cells that our pancreas is just so overworked that it doesn't work anymore. But basically you have to understand that we have some insulin. It's being produced, just not enough for what we have. Our beta cells are failing, and it is more common in adults. It used to be something you'd only see it in, much older people. Our younger folks are more likely to have that type 1, but again, there's a big overlap. You can be 30 and get type 1 diabetes. You can be 14 and have type 2 diabetes. I mean, it happens, definitely. So just understand these are kind of general rules. Just understand that it doesn't work very well. And if we don't maintain our diabetes type 2, it can become where our pancreas is really failing, and we do have to have insulin. Most of these people are on anti-diabetic medications, which is the oral, but as it gets more severe, you may have to really look at insulin and injections. So typically our type 1s they just have to have it, insulin. Our type 2s may develop into something where they have to have it. So definitely know your difference between these two. So type 2 diabetes typically has a slower onset than type 1 diabetes. It still has the polyuria, the polydipsia, the polyphagia. It is aggravated by things like sedentary lifestyle, a family history, increased blood pressure, obesity, all of those things. I'm fairly well convinced that type 2 diabetes is genetic, but we have to understand that obesity does make it worse. So if we're not eating the right foods, if we have a sedentary lifestyle, it can get, it can really aggravate it, where maybe it would just be a minor case of diabetes, but now with the other factors, it's much more severe and much more damaging. So there's other things that we might see, like a recurring yeast infection. That happens because we get those, in the vagina you have a very acidic environment. It keeps all that bacteria under control. But in diabetes, the vaginal secretions have more glucose, and then the yeast feed on that glucose, and it allows it to grow and multiply. Just like diabetes type 1, you will have a lot of issues with microvascular and macrovascular complications. So all of this has to be managed, including our wound care, because we know diabetes type 1, diabetes type 2, it doesn't really matter. You will have issues with your skin and wounds not healing very well. The risk factors we have to look at for type 2, again, increased body mass, physical inactivity, high levels of triglycerides, and low levels of our good cholesterol, metabolic syndrome, and prediabetes. So we know that that level between like 5.7 and 6.4 of our A1C is considered prediabetes. If you have prediabetes, you are very you're just much more likely to develop diabetes. Overweight clients should be informed that if they lose 5 to 10% of their body weight, it will decrease their risk, and it also decreases that insulin resistance, making that whole system work better. So losing weight is a really good place to be. Again, I think a lot of this is genetic, but if we control some factors, we can control the diabetes and at least manage it much better. Diabetes is something that we cannot ignore. That's that that's that A1C that's 5.7 to 6.4. We want to know what this is. We want to know that if you have diabetes, we want your number to be under 7. So it's very important to look at diet and exercise. It's very important to look at weight management. And it's really good to get these changes done before there's permanent damage. When you have diabetes, you are much more likely to have a stroke. You're much more likely to have a heart attack. It's better to manage these symptoms before those things happen. So do not ignore things like prediabetes, because we can stop a whole cascade of problems, which happen, very long term. So 20 years into having diabetes, the damage is done. We need to make sure that they understand that we can't ignore this with something we need to figure out and educate them to. The diagnosis of type 2 diabetes is done through an evaluation of labs, our A1C, our fasting blood glucose, a postprandial blood levels. If they're above 200 after eating, that's a little high. Oral glucose tolerance test, that's one that's usually done with pregnancy, and that's the, you take like a weird orange liquid and then they take your blood a few hours later. Manifestations of diabetes plus the causal blood glucose concentration of above 200. We're going to look at that and say that's probably positive for diabetes. So the difference in between 1 and 2 is more based on situational, versus time or specific lab values. It kind of depends on how much function we still have in the beta cells. If hyperglycemia is noted in the physically inactive, overweight, we're going to kind of look at oral medications and diagnose it more as type 2. And you can have really severe type 2 diabetes and have to be on insulin. Usually that's a progression. So what I did in clinic and what I was advised to do by the powers that be is we would, of course, start with things like metformin, and then we could go to a glipizide, and then you would add maybe a third, maybe an Actose or something, medication. By the time you got to that third anti-diabetic medication, we would send them to endocrinology after that point, because it wasn't clearly being managed by anti-diabetic meds, and it probably needed some more aggressive treatment, even possibly insulin. But again, once you got on more than 3 anti-diabetic meds, we were going to send you to endocrinology. So treatments, again, we want them to lose some weight. We would like to watch for complications, monitor their glucose, focus on nutrition, exercise, and again, don't be afraid to use your resources. If you have someone in your hospital that, a dietitian, use them, especially if you have a brand new patient that's diagnosed with diabetes, because this is information they're absolutely going to need to have. But again, educate, monitor that glucose, nutrition, exercise, and then definitely warn them, educate them about what happens if you don't take care of this. The wound healing that's really bad, the possibility of losing toes and losing their eyesight, and really the number one reason why we're losing like people lose feet and they lose, they have those below the knee amputations. It's because of diabetes. It's either, an accident, but a lot of times it's something that we can prevent with a lot more education and monitoring of those diabetes symptoms. So our interventions, our pharmacological interventions for type 2 diabetes always start with oral medications. The first one is one of the biguanides. Well, there's only one biguanide, it's metformin. So they're going to start on metformin along with diet and exercise to hopefully make some adjustments. It'll help. Metformin works by helping the liver break down less glucose, so then it decreases the blood glucose levels. It also helps decrease insulin resistance. Sometimes people might be allergic to metformin and then they probably go on a glipizide, but it's a possibility that they could be on 2 medications or 3 medications. So it just really depends. There's like many different classes. So here we have listed 7 different classes of type 2 diabetic drugs. I think there's really a total of like 9. I think there's some more classes. You don't need to know everything about everything, just know that they exist. In pharm, you'll be touching more on what type of meds and how they work in the body and all that good stuff. So just understand type 2 will start with oral, type 1 is insulin dependent, so they have to have insulin. So type 2 is oral. So let's look at our type 2 complications. We have our HHS, which is like our DKA, but it is without ketones in the urine. We do have a depressed immune response. It can lead to infection and poor wound healing, and both are considered acute complications of hyperglycemia. Prolonged hyperglycemia adversely affects blood vessels and nerves. Because the entire body relies on these networks, the long-term effects are extremely widespread. You can have macrovascular complications. So macro, meaning larger vascular complications, large arteries that supply the heart and brain. We can also have microvascular complications involving damage to our small blood vessels. That's where we see those problems in the periphery, the toes that people lose, and sometimes that microvasculature in the eyes, and it leads to blindness. So hands and feet, you can have that neuropathy, numbness, tingling, and pain. The question is, if they have numbness and tingling and pain, do we want them to walk around barefoot? One of the appropriate nursing interventions for someone with diabetes is a risk for infection, and it is going to be at a higher risk if they walk around barefoot. I have seen many, many times people losing feet, losing toes due to infection. Anyway, this is severe damage. It can be very painful or it can be very numb. This is also, we see those people that have those deep tunneling wounds on their feet. And if you've seen them and you've seen them unpacked, and you're like, how did you not know you had this big wound on your foot? Well, they don't feel it. So we need to educate them to see a podiatrist regularly and to really investigate their feet and take a look at it and make sure that we're not surprised by a giant wound. To do an assessment of our diabetic patient, we're going to look at vital signs, glucose, how well are they at performing self-management, the insulin or oral glucose control methods, capillary refill time, skin assessment. You see that's bolded there. We definitely want to look at their skin. Intake, output, and laboratory tests. Let's also consider our carbohydrate intake at meals. So vital signs, we may see a decreased blood pressure and increased heart rate secondary to the volume deficit created by hyperglycemia. So again, that polyuria, they're urinating a lot of their fluids out, they're probably going to have low blood pressure and increased heart rate. Temperature may be elevated if an infection is present. We want to see what their glucose is. What has it been running? What has it been for the last week or month or few months since they've been in? If they have poor diet, weight gain, limited exercise, we need to address these. Are we managing their diabetes properly? So maybe a diet journal. Self-management is really, really important. Blood glucose needs to be monitored as prescribed and medications taken as prescribed, as well as following a healthy diet and exercise. we want them to count their carbs. What we find a lot with our diabetic patients is that they've kind of learned to cheat the system and do whatever they're going to do, and then maybe cover their overages with insulin, which is still causing a lot of damage to their vessels. They don't seem to understand that just because they can manipulate the numbers doesn't mean that they're not having damage. So the way that we try to, manage diabetes is to prevent that vascular damage, and they're not doing it when they're solely looking at the numbers. Look at your capillary refill in your lower extremities. We want to make sure we don't have decreased perfusion. That microvascular changes can cause, capillary refill delay. And again, like I said on the previous slide, look at your skin assessment. Look at your lower extremities. Look at your wounds. Look at your feet. I've had people, come in and they've had an infected toenail. It's gotten out of control, and now we've had to do an amputation, like a below the knee amputation, because the infection has gotten so out of control. So make sure that we're assessing our patients and their skin well. So with our nursing interventions / patient education, one thing to consider is possibly a medic alert bracelet, especially if there's someone who is prone to hypoglycemia and they pass out. It's really nice to know that, what direction we should be going in if they have a medic alert bracelet. We need them to know insulin is not available in pill form if they don't take care of their diabetes, and, they're really into avoiding needles. They really need to manage this well because insulin cannot be given orally. How do they maintain a healthy lifestyle? Meal planning and exercise. What are their signs and symptoms of hypo and hyperglycemia? They want to keep and always should have a drink or a snack with them in case they start feeling hypoglycemic. It's important that the patient and the family are able to detect early signs of both hypoglycemia and hyperglycemia, because unfortunately, if they start slipping into that, they may not notice it themselves. We were talking about diabetic brain earlier of, you may be conscious, but you're really not thinking clearly, even though you're alert. Well, you seem like you're alert, but you're not really very active. Then that's one of those signs of hypoglycemia. Make sure that they have really meticulous foot care. We want to avoid wounds, infections that can result in amputation. Podiatry, make sure that they're seeing them. I think they can see them every 60 days for toenail trimming, and monitor for complications. So, again, journaling. Let's make sure where our blood sugars are at. Are they well maintained? Do we need a change in our medications because we're not really seeing the improvement that we want to see? What is the diet like? All of this is very important, and we have to follow up on it. It's very important that we understand that we are part of the management team, but not the sole all be all of this. You don't have to know everything about everything, but we need to know what our resources are. We need to understand that pharmacy should be involved to make sure medications are affordable, to make sure they're promptly delivered, to make sure that there's no interactions. We need, a dietitian really to help with that care, because we have a certain level of carbs we have to have. Good quality carbs that don't spike our blood sugar, proteins and fats. And it's a little different, from a person that does not have diabetes to a person that does have diabetes. We need somebody that is an expert in diabetes care, an education specialist. You can even, there's support groups, there's education groups that will really help clarify, this disease. And we also need our primary care physician to be involved. So again, if we can take our journal and we can take that to our provider and they can see trends up or down, then we have some adjustments in medications. Realize that as a nurse, you are part of the team and you are there to educate. And if there's something, you're seeing like a trend higher in numbers, yeah, let's get our physician involved. Let's get our pharmacy involved. Maybe they're struggling with their diet and we need to get dietary involved to help really educate them to their needs and their diet. So let's definitely invest and use our team members appropriately. So the biggest issue about diabetes is really the long-term complications. So diabetes, like hypertension, can be a very subtle disease. Not always, but it can be very subtle. And so then when we start displaying problems, the damage is already done. By the time we have a huge foot wound, the microvascular damage, it has already been done. By the time we have people losing their eyesight, that damage is already done. So, even though it may take 10 or 12 or 15 years to start seeing the damage from diabetes, it's really important to let them know that these changes have to be made now so that we're going to see, a much better quality of life than, 10, 15, 20 years from now. We need to look at, again, that difference between the macrovascular, so your large vessels and arteries, your cardiovascular disease, your cerebrovascular disease. Those are macrovascular big problems. You are more likely to have a heart attack, a stroke, more likely to have hypertension because of diabetes. Diabetic retinopathy, that's those little tiny vessels in your eyes. And so we know that diabetes affects the microvasculature and it can cause blindness. Diabetic neuropathy, it's that numbness and tingling in your hands and feet. It's extremely painful for some people and it causes just abject misery to have that pain. And then other people, they feel nothing, but they get those infections and they get those wounds. And it's really affecting the quality of their life. So we also have to look at things maybe we can't see. Damage to the kidneys, damage to the blood vessels. It allows, if we have damage to the kidneys, kidneys don't work. Then you have kidney failure, and that progression, can lead to, severe lifestyle issues. If we have to have dialysis, it's going to be quite catastrophic if we don't manage these problems early. And it's a good thing, not to scare your patients, but to really educate them like, hey, we need to take care of this now so it doesn't become a problem, 10 years from now where you're dealing with blindness or amputations or kidney failure. So, again, I don't want to scare them, but let's take it seriously. So there is something we want to consider, which is the sick day rules. This is something where sickness really affects diabetics a little different, but we want to continue to take our insulin and our anti-diabetic meds as usual. We want to have them test their blood sugar every 4 hours, drink, your calorie-free liquids and eat, weigh yourself. If you have a lot of real quick weight loss, it could be a sign of high glucose because remember that polyuria, you're not holding on to your liquid, and that weight loss of a couple pounds really quick could be a sign of hyperglycemia. Not that you're doing super well on your diet, but hyperglycemia. So make sure you check your temperature because we don't want you to have an infection. Drink lots of fluids to prevent dehydration. And try to get your carbs, try to get your 50 grams of carbs every 4 hours. Drink small portions of sweet beverages to keep your blood sugars, from getting too high. If it becomes an issue, you may have to go and see the doctor. We want them to go to the emergency room if they're having trouble breathing, if they have really high ketone levels, if they can't keep any liquids down for more than 4 hours, if they lost 5 pounds or more during the illness. If blood sugar is lower than 60, but I guarantee if it's 60, they're probably not super cognizant of that. So remind the families, if they get too hypoglycemic, we're going to have to take them into the hospital. If they're not able to eat, if you feel so sick for 24 hours, we know that's going to mess with everything. And again, if they're continuing to take their insulin and their diabetes medicine when they haven't eaten anything, oh boy, it's going to be a big problem. Vomiting and diarrhea is going to mess a lot of things up. Temperature means we have an infection. If they feel sleepy, if they feel like they can't think clearly, we probably need to go to the emergency room. So I want you to understand that these are things that are very concerning and very serious. And I will tell you, my husband has a cousin who's diabetic who did die from this. He wasn't feeling well. They called the doctor a few times, but he lived by himself. He probably went hypoglycemic, and they found him passed away a couple days later. So it's something we have to take seriously. If you don't feel great and we know you're off, let's go to the hospital. Let's manage it there. So we have some patient resources, the American Diabetes Association, the American Association of Clinical Endocrinologists. These are good resources for your patient to have because you're not always going to be there. Usually in the hospital, once they've been diagnosed, they're going to spend some time with you and then they're going to go home. And then they're going to be like, now, what did she say? Because again, we get there, we info dump all over them. They're not paying attention. They're ready to go home. They're so anxious and they don't remember half of what you said. So give them some resources where when they get home and they're starting to think a little more clearly, then they can reach out. I want you to spend a couple minutes, look through these patients, and I want you to think about prioritizing them. We've got John Johnson, we've got Steve Smith, and Helen Wilson. So take a look through these vital signs, take a look and see who you would go and see first, who you would see second, and who you would see third. And then on this next slide, we'll investigate why they'll be in that specific order. Here's our rationale for our prioritizing patients. We're going to see Mr. Smith first. That hypoglycemia is really severe. We want to make sure that we're addressing that mental status change. That's super important. We also want to see Mr. Johnson next because alcohol depresses that release of glucose. And then we're going to see Miss Wilson third. She is presenting with serious but very, very common issues, things like gastroparesis possibly. But I think that she is relatively okay for now. I mean, again, you look at her pain, 7 out of 10, very severe, but we are much more concerned with mental status changes and addressing those. So let's look at this question. Nurse is assigned to care for 3 patients on a med-surg unit. We have these 3 patients, and patient A, known alcoholic with a finger stick of 60, diabetic patient complaining of 6 out of 10 abdominal pain, nausea, vomiting, and C, an elderly patient with type 2 diabetes and confusion. So our priority is going to be, again, our mental status change, our person that is elderly with type 2 diabetes. I'm absolutely concerned about A. I want to see if we can address that blood glucose. Abdominal pain for B is pretty severe and concerning. We're going to see all of these patients, but let's look at C first. Let's see our case study. We have Mrs. Simpson, 63-year-old African-American female with a history of type 2 diabetes, admitted for an unstable angina. She is now 4 days post-op following a triple cardiac bypass. So let's look at her vitals. Room air, 9702. Looks like BP is okay. Respiration's normal, heart rate's normal. Temperature, looks like it's a little elevated. Let's look at these labs and the vitals. What can we tell? So we know that there's probably an infection present because we've got elevated white blood cells. Glucose looks like it's a little elevated as well. And we have some sort of renal insufficiency because the GFR is at 27. So blood and urine cultures are sent. She started on antibiotics. Blood glucose level is increased because of the infection, requiring insulin coverage. One thing you will see in the hospital is we don't tend to use as many anti-diabetic medications. We do use insulin because we have a little more immediate control of what's going on. She's also started on intravenous fluids, and we want to make sure she's urinating well. Renal function is closely followed with the daily laboratory assessments. Simpson is now 6 days post-op following her triple bypass. Cultures reveal a urinary tract infection, and she started on Bactrim. Vital signs are stable, temperatures within normal limits, and her white blood cell count is back to normal. During her hospital stay, diabetes is treated with insulin. She's given nutritional, correctional as necessary, and basal insulins. Her blood glucose is back within a tight glycemic control after the initial increase with the infection. Urine output is stable. Renal function tests appear to be normal. So the plan is to discharge her tomorrow. So our practice question, the nurse includes which information in the teaching plan for Mrs. Simpson? We have these 4 options. So pause here if you want to look at the question for just a second. So your answer is D, as in dog. Infection may impact Mrs. Simpson's glucose levels. She should not go home on insulin. Because she's a type 2 diabetic, she's going to go home on the anti-diabetic meds. Again, we use insulin in the hospital for tighter control, but it's not something she needs to go home on. We're going to monitor glucose levels, several times a day, and there's no need to eliminate fat in the diet. Statement by Mrs. Simpson about her home medication regimen indicates the need for further teaching. So we've got these 4 answers. Again, I want you to pause this recording and make a guess at which one you think it is, and then we will go over the answer. So your rationale is answer A. Renal disease may lead to lactic acidosis if taking metformin, so it should be monitored. So what she's saying in statement A is not correct, so therefore she needs further teaching. Statement by Mrs. Simpson indicates that teaching has been effective. The same as before, take a look at these 4 answers and then put your guess in, and then pause the recording and we'll go over the answer in just a second. So your answer is going to be C, as in cat. Infection or stress may lead to increases in blood glucose. Heart surgery does not cure hypertension. Diabetes mellitus is associated with heart disease. Patients should not take 2 pills together to make up for a missed dose. So the nurse recognizes that the management of diabetes is most successful with which action? Look at your 4 choices and pause this so that you can answer the question. So your rationale, your answer, is C, as in cat. All answers are essential for diabetes management, but the patient's commitment for self-management is necessary to maintain the necessary measures for optimum diabetic management. Recognizes the action of insulin is to, let's look at these 4 answers and then pause this recording so you can guess which one. The answer is D, as in dog. The idea is to transport glucose across the cell membrane. Remember that analogy we had at the very beginning, that it is like a key and it opens the door so then glucose can go into the cell. So other answers are incorrect, and it is to transport glucose across the cell membrane. Are considered clinical manifestations of type 2 diabetes. So these are, this is a really good question to know. You will see this over and over again. Diabetes is so common. You will definitely be asked on the NCLEX, what kind of clinical manifestations are you going to see? So take a look here and pause your recording so you can get the answer. So the correct answer is B, C, and E. So boy, cat, and elephant. The rationale is that decreased appetite and hyperactivity are not associated with type 2 diabetes. Poor wound healing is due to decreased peripheral circulation. Visual disturbances are due to microvascular effects of diabetes. Fatigue is due to the breakdown of fats and proteins for energy needs. Everyone's favorites, more select all that apply. Look at this. The nurse understands that type 1 diabetes is caused by which of the following conditions? So take a look at these 5 choices. Remember to treat it as a true or false. And then pause this, excuse me, pause this so we can find the answers and then come back. So the correct answers are B as in boy and D as in dog. Type 1 diabetes is caused by an autoimmune process in which the insulin-producing beta cells of the pancreas are destroyed. Triggers are not fully understood, but a history of mumps or rubella is sometimes implicated. Monitors for which clinical manifestations in the patient newly diagnosed with type 1. All right, so On this one, it's A, B, C, and D, not decreased appetite. Remember polyphagia, which is that increased appetite, is part of the symptoms. So decreased appetite doesn't make any sense. So you're going to see a lot of urine, you're going to see fatigue, weight loss, and an increase, appetite, because our cells are not being fueled right. So our body's kind of being tricked into feeling like it's hungry. These are all clinical manifestations. Glucose is typically, it's reabsorbed in the renal tubules. Hyperglycemia results in glucose excretion in the urine, which causes an osmotic effect. It effectively reduces water reabsorption to the renal tubules, leading to excessive volume loss through the kidneys. Hyperglycemia also causes hyperosmolality in the blood, which causes a shift of fluid from the intracellular space to the vascular space. The loss of intracellular water combined with the volume loss to the kidneys creates excessive thirst in the patient, or polydipsia. The lack of insulin necessary to move glucose into the cells leads to the breakdown of proteins and fats as a source of energy. So the starvation leads to polyphagia, increasing the appetite. Despite an increased appetite, it will actually not cause weight gain. This continual breakdown of fats and proteins lead to weight loss and fatigue. Correlates which laboratory value with the diagnosis of diabetes? So that would be A, fasting blood glucose of greater than 140. The others are indicative of prediabetes. So 140, you haven't eaten in a long time, your blood sugar is still super elevated. So that's definitely a good direction for us to consider diabetes as a diagnosis. The nurse should intervene immediately if a patient has which glucose level? Your answer is going to be D as in dog. So hypoglycemia is extremely deadly. If we don't have fuel to our brain, it does not work. Our brain shuts off. If we have a brain that's shut off, we're not doing anything, breathing. We're not functioning. We're not, our heart's not beating. Things are really, really, really bad. So low blood sugar is much more of an emergency. Not that we don't deal with hyperglycemia as an emergency. We certainly do. But looking at all of these numbers, people hang out at 200 all the time. 80, 152, those are pretty good numbers, actually. I mean, it's not the end of the world at all. But 40 is detrimental. We need to intervene at 40. Nurse recognizes that blood glucose monitoring before meals and at bedtime is done to achieve which outcome? Select all that apply. Pause here and go through and select which answers you think would be most appropriate. So the correct answers would be A, B, and C. Blood glucose monitoring before meals and at bedtime facilitates insulin administration that mimics the healthy pancreas, which helps maintain glycemic control and prevents complications of long-term hyperglycemia. The goal is not frequent practice. Acute complications can occur independent of glucose monitoring, such as infection or stress, which increase glucose needs. Nurses reviewing orders for patients newly diagnosed with type 2 diabetes. What initial medication orders should be anticipated? So let's take a look at this and then pause this and let's see what answer you come up with. All right, so the correct answer is A. Our first drug that we try for type 2 diabetes is metformin. Unless there's some reason we think they're allergic to it, we're going to start on metformin twice a day. It could be once a day, but twice a day is not a bad thing. Insulin can be used later if we cannot maintain our glucose control. Really, B, C, and D are used for type 1 diabetes. So type 2 is typically the oral medications, and we start with the biguanides, which is metformin. So which of these answers is most appropriate? So the nurse is prioritizing which nursing diagnosis for the plan of care in a patient with type 2 diabetes. Your answer is A, risk for infection. So diabetes type 2, are we worried about them falling? Probably not. Gas exchange, hyperkalemia? Not necessarily. Most likely we're talking about infection. That's one that, we have to always be aware of and understand that along with the other diabetic concerns, infection is very important to address.